So today's topic is not for the exam purpose, right? Because they are going to be a dentist soon, so you qualified soon. So it's good to know how we do orthodontic in the private practice or in the real life or even the government practice. So a lot of time, this orthodontic treatment is not only means ortho only. A lot of time we involve other team as well. So you have to cooperate with the other doctor. If you're not alone, then you can send it to the other clinic. So you can be a field specialist in your clinic. If you're lucky, then you can send to a periodontist or a surgeon. Pete, resto, prosto, there's so many specialists involved. Of course, you're a single practice, then maybe you're super GP. They can do everything together, but it still involve a different team to do it. Huh? So, sorry, not involve different team. If you do it alone, it can be involved so many disciplines. Huh? You have to treat the perio, then you have to restore the bridge or the implant later by yourself. So, although a lot of time if you do it in private practice or in real life, it involves so many teams. So today's topic is a multidisciplinary team approach in orthodontic treatment. So it simply means the involvement of different disciplines in the management of one case. So it can be discussed under a few topics, but today we're just going to focus on adjunctive orthodontic. Management of cleft lip and palate patients, I think we discussed before. And then management of orthodontic cases also we discussed before. So today we're just going to focus on the first topic, which is adjunctive orthodontic. Okay. Well, what's the key requirement if you come to this team approach? Then there's so many members involved. Then there's a few key requirements you have to remember. First is a joint planning. It's never just planned by one person, not by the orthodontist, not by the periodontist, not by the pits. Everyone will come together as a team. That's how I have to plan the case together. So usually in the government or the private, we organize a joint meeting or the joint clinic. These joint clinics, then a few specialists will come together and will bring in the patient, then we'll see the patient together. And together we decide what's the best to do for the patients. Then we finalize the treatment plan. So involve teamwork. It's never one person do everything. Like myself, I'm so lazy. I only do braces. So other fillings, perio, whatever resto work, then I refer to my other colleague. Then you need the regular joint review. Doesn't mean the first joint meeting, they decide the final treatment plan, then you leave the patient alone. A lot of time you have to bring the patient back to the joint clinic, then review them together. So we other specialists will see what is the progress, then we'll give some opinion, then why we want to change. Sometimes we want to change the treatment plan a little bit according to the updated or current situations. So joint clinic, it means not only one time, you decide the treatment plan, and halfway through the treatment, then you bring the patient back to the joint clinic for the review, then review the progress, then finalize the treatment plan or modify the treatment plan again. So what's the factor influencing our treatment plan or the treatment mechanic? So general factor can be patient age. So if you come to joint clinic, it means there are complicated cases. So a lot of teenagers, then usually straightforward, then we take out 4 premolars, then upper and lower braces, then end up a nice and straight teeth at the end. But when it comes to adult patients or some complicated cases, then usually they are adult or senior citizen. So usually patients at younger age, then they can sustain the braces a bit better. So sometimes the forces we use for adult patients or senior citizens have to be very light, and you have to be very patient with the two movement compared to teenagers. So patient age can be a main factor to be considered. Then when the patient is too old, then maybe sometimes not suitable for braces. When they're too young, also not suitable for braces. So patient age can be one of the factors you have to consider. So growth potentials. So this one I think we discussed before. Growth is a very important factor in orthodontic treatment. So if the patient is still growing, there are more you can do. You can do some jaw modifications or growth modifications. Then the patient stop growing, then when it comes to severe case, then you need surgery to do it. So growth potential is very important. If the patient is still growing, then usually the teeth will move a bit faster compared to the adult, which is stop growing. So we always tell the adult, then the teeth will move a bit slower compared to teenagers. Is the slide okay or is lagging?
Yeah, it's okay.
It's okay. Huh? So the general medical condition, it just means the patient general health. It can be some patient have Down syndrome, even though they want the treatment, then a lot of time maybe they're not suitable because they cannot take care of the oral hygiene very well. Huh? So general medical conditions also have the need to consider. So level of patient motivation, this one I would say is the most important thing. Huh? If the patient is not care, then they're not interested with the treatment, then there's no point having the complicated treatment. So patient motivation is very important. Huh? So we always do it if patient want it. Except the CLAP patients. CLAP patient, we do it for other purposes because we want to do the APG. So whether the patient like it or not, you still have to do it. But when it comes to other treatments for perio, resto, then always the patient motivation is important. Patient want it, we do it. If patient not care, then maybe we will do it. The patient's treatment usually is a bit lengthy and you need a committed patients. Huh? So because this one is complicated treatment, it's very long treatment. So patient have to be very committed. So what's the dental factor you have to consider? So the level of dental awareness. Some patients, even though they have a lot of problem, they don't really know they have problem. So for example, that patient have multiple caries, retained root, then they come in the clinic and they say they want to do whitening. It's quite frustrating, no? Because they don't know what's a priority. So this kind of patient may be not suitable for this joint clinic or the joint team approach. So dental level of dental awareness is very important. So when it comes to multidisciplinary approach, then patient need to have a high dental awareness. The stage of dental development, this one again, it comes to the age or coronary fractal. So if the patients that have a young and mixed dentition, maybe you can do some simple treatment. Then you have to divide the treatment into a few stages. But the patient is already old enough, maybe you can start the treatment. If they're still growing, maybe you tend to wait if there's severe skeletal problem. And we are reach with, so this one is we are talking about how long the tooth have been missing. So for example, this one patient extracted the tooth for too long, then the ridge will resorb or the bone will resorb and end up what we call the sharp edges or the knife edge ridge. So when it comes to the sharp ridge or the knife edge ridge, then it's difficult to close the gap. Morphology of the adjacent tooth. So we're talking about the next two, whether they are in the nice proportion and shape or not. So it can be the peg shape lateral incisor, which is very common. So orthodontic factor, what to consider? So underlying skeletal pattern. So if there's severe skeletal pattern, then maybe we tend to do surgery rather than camouflage. Then soft tissue pattern. Soft tissue pattern can be the lip posture or the lip profile. So you have the protrusion lips, and maybe you want to bring the incisor back. Malocclusion can be class 2, class 2, class 3. Then two tissue ratio. So this we are talking about the supporting tissue. So it is the ligament peritonium, the bone and the gums around the tooth. Tooth size discrepancy. Tooth size discrepancy, it just means the size of the teeth in general. So you measure the size of the upper teeth, they have to match the lower teeth as well. So when the upper teeth is too small, then lower teeth is too big, then you have the tooth size discrepancy. Same thing, if you have the upper is too big, then lower is too small, then you tend to have this tooth size discrepancy. So if the tooth size discrepancy is too big or too huge, then sometimes you have to modify the shape and the size of the teeth. So a lot of time, then when we come to difficult treatment, then we will do the wax up just to simulate the final result. So a lot of time we take a mold. So you can see on the left side, we take a mold, then we send to the lab, then we cut the tooth away, then we rearrange the tooth back into the final position we want to. Then we show it to the patient, then we show it to other specialists, whether they're happy with this final setup. Then once we are happy with this final result and the setup, then we will start the treatment. So the waxing or wax up is very important step for the multidisciplinary approach. So the establish a realistic treatment objective. So when it comes to difficult treatment, You not always have to get a class 1 molar, class 1 incisor, class 1 canine. So a lot of time we come to difficult treatment, then the result will be compromised. A little bit imperfection is okay. So you don't have to get the perfect result when it comes to difficult treatment. So you have to establish a realistic result rather than a perfect result. So you have to visualize the treatment objective. If you cannot see the final result, you cannot visualize it, then most probably you can't achieve the result. So you have to be able to visualize the final treatment outcome. So diagnostic workup, like I say, is very important. So you have to determine the sequence of treatment. So after everyone agree with the treatment plan, then we have to determine who will start first. Orthodontist will start first, periodontist will start first, or restorer will start first. Who will come first, who will come later. So that's the final plan. So we usually need the adjunctive specialist care when it comes to difficult treatment. So what's adjunctive orthodontic? It just means we need the other colleague help. It's not only ortho, we need a perio, resto, prosto, oral surgery. So the definition is the two movements carried out to facilitate other dental procedure necessary to control the disease and restore the functions. So that's the definition by Profit. Profit is a very famous orthodontist. So the first one, it can be facilitate the restorative work. So by positioning the teeth, show that the more ideal and conservative treatment can be carried out. So for example, rotated tip apartment teeth. If you want to cut it, become a bridge, then usually have to tip it back to the vertical position. So when you cut the crown, they won't expose the pulp. So inadequate pontic or implant space or excess space. Sometimes the space is not ideal. It can be too big, too small. So you need braces to close it, or you open up the space so the space is ideal for the restorations. So for example, in this picture, you show that the lower incisor, so you need two incisor space to restore it. So you have to need the braces to redistribute the space to the ideal then before you do the restorative work. So on the right side, it just shows that one adjacent tooth is tilted forward due to this missing molar. So if you cut the tooth or the bridge, then this one might most probably expose your pulp. So we use the braces. You see there's a mini screw at the back. Then this mini screw can upright or drag this second molar backward. So by doing that, you can upright the molar, then you can do a better restorations work. So it can be helping the periodontist or the perio colleague. And how we can do it, it can help to straighten the teeth. Then you can eliminate the plaque harboring factor. Straight teeth is always easier to clean compared to the crooked teeth. Then establish a favorable crown root ratios so that occlusal force can be transmitted along the long axis of the tooth. What it means is when you come to the fracture root, then a lot of time when you want to cut or you want to do the crown, then you usually do the pose. But this ferrule is very important. It means you want to cut, you want the remaining sound tooth structures to hold the crown. So when you come to the flat surface, even you do the pose, they are not good in holding the crown. So what we do, we use the braces to extrude the tooth. So you can see how much we extrude the tooth. Then you need about 2 to 3 millimeter minimum, the height, before you can do a good crown. So if you just do on the flat surface, then most probably after a few months, even years, then the crown might be fractured. So this is mean auto extrusions. You will achieve the better crown root ratio. So this one is the crowding. It's more prone to these plaque accumulations. Okay, so we're going to talk about ortho-perio management and or periodontal compromised dentition today. Then we're going to talk a bit about the ortho-prosthodontic or resto, which means we're closing the gap or opening the gap for the prosthesis. And we're going to talk about a little bit of oral surgery, which is management of atopic or uninterrupted tooth and even implant. So the first topic we're going to talk about today is ortho-perio. So a lot of people think this malocclusion will cause some periodontal breakdown. So the factor associated with this increased periodontal breakdown can be due to class 3 malocclusion. So you can see on the top right picture, this class 3 patient sometimes have the initial bite with a functional shift. So we talk about this many times. Functional shift, it means you have initial contact on the anterior, posterior, then the jaw will shift left, right, front, back. Then this one considered functional shift or displacement. So when you have functional shift, then it tend to cause a occlusal trauma, or it can cause a heavy force uncertainty. Then in long term, it might damage the periodontal support around that too. So anterior crossbite, typical. So it's usually the central incisor involved. Then if you look at this picture, then you see the gum recession due to the heavy occlusion force. Deep and traumatic bite. So sometimes deep bite, you have to check whether they have a trauma to the lower incisor, attritions, and the gingival recessions. Severe crowding, again, is linked to this foot or the plaque accumulations. So in long term, it might damage the periodontal support. So you see this deep bite, it causing the stripping on the lower incisor. Then it's causing these attritions on the incisor edge. So when it comes to deep bite, you always check the occlusal trauma, whether they are on the tooth or on the soft tissue. Again, this one is a cross bite. So you can see this upper incisor, one is pushing the lower incisor forward. So in long term, they might cause some periodontal damage on this particular tooth. So when a cross bite, always check on the tooth first, hard tissue, and second on the soft tissue, the gum. Of course, you can check the mobility also. So what's the objective? If you do braces on the periodontal compromised patients or periodontitis patients, so that's the objective we want to achieve. So first thing, we have to achieve the parallelism of the abutment tooth. It means you make all the teeth straight. So when the teeth are straight, then the occlusal force can direct to the root straight. If the tooth is tilted, then sometimes the occlusal force is direct to the crown rather than the root. Then favorable distributions of the tooth or the teeth. So sometimes the tooth can be falling apart to each other. I mean, they cause a lot of spacing between the teeth. And sometimes the space is not ideal. So what braces can do redistribute the space. So you can restore the tooth with the dentures or even the bridge. Then good embrasure space and root proximity. Then this one, the same thing. So if you have a tilted tooth or crowded tooth, sometimes they are not able to clean the embrasure very well. So compare have a straight teeth, when everything is straight, then usually that back triangle, you can clean a bit better with the interdental brush or even the floss or super floss. So we can adjust the occlusal plane and incisor guidance. So you all know the incisor guidance is very important when you grind your jaw forward. So braces can adjust the incisor guidance and even the occlusal plane also. Then adequate occlusal relationship functional. So sometimes if the teeth is tilted or they're crooked, they have space, and sometimes the occlusal force is not equal on every single tooth. So what you can do, you can align the tooth and get a better occlusion. Okay, and we can get the patients a bit better self-maintenance or periodontal help. Like I say, straight teeth is always easier to maintain compared to crooked teeth. Then aesthetic improvement. You see, I put the aesthetic improvement as the last objective. So when it comes to compromise periodontal support patients, then the aesthetic is always my last concern. So I think I mentioned this many times. The function is more important than the aesthetic. So you consider aesthetic as a bonus for this kind of patients. So the function always comes first. Remember, function always comes before the aesthetic. Of course, there are some doctors might disagree with me. So this one, some people will think aesthetic more important than functions. This one is personal. So what's the rationale for doing patients, for doing braces or orthodontic treatment on periodontal compromised patients? Is to promote the better dental health. Of course, you can clean better, maintain a better oral hygiene. Then the second is to prolong the life of the patient's dentitions. You try to prolong the life. It's not make it beautiful, but you make it last longer in the mouth. That's my purpose for doing braces treatment. Okay, I think my perio knowledge is already outdated, but this is what I remember from my undergraduate days. So I think the healthy periodontal tissue, once you have these plaque accumulations, then it becomes a gingivitis. Then gingivitis will become a periodontitis if you ignore it. And also, if you do an effective cleaning, then you can reverse the periodontitis to a healthy periodontal tissue. Then, of course, if you're talking about bacteria, then from the anaerobe, then gram positive, then slowly become a gram negative and anaerobe. Then the plaque can be from the supragingival, then slowly become subgingival. They slowly grow bigger and deeper. So until it becomes subgingival, which is difficult to clean. So the classifications, I think now they have a new classification. For my time, it's only have an acute and chronic. Then we have another one is called juvenile periodontitis. I think it's a bit outdated. So orthodontic tooth movement in an adult with periodontal tissue breakdown. So can we do braces on periodontal compromised patients? So let's say if a patient has periodontitis, then can we do it on this kind of patients? So we're going to talk about it. So I think you remember I told you many times. So the two, if you want to stabilize the two in one position, then the two subject into a few forces. So it can be from the labia, from the lips, then it can be from the back, from the tongue. Then you also have your own periodontal support. Then of course on top you have the opposing two with causing the occlusions force. So these four forces have to come into balance in order to maintain the two into the positions. So either force will become bigger, then the two will move in either direction. So let's say the lips is stronger than the tongue, then a lot of times these two will be retroclined. Then if you have tongue thrust, then the two will come forward. If there are severe occlusions from the top, then these two will become slightly mobile if you have a compromised periodontal support. So these four forces is very important when you consider the treatment plan for the patients. So can we do braces on these kind of patients' periodontal problem? So according to a few ortho or a few specialists, they did some research back to 1970. So inflammation might cause periodontal tissue destruction. This one everyone know that. So what's the cause for inflammation is a plaque accumulation. Then inflammations, if you plus a bit of occlusal trauma and orthodontic forces, then may produce rapid periodontal tissue destructions. What I'm trying to say, if you didn't control the plaque or the oral hygiene, then whatever you do on that too will cause more damage and it happen very fast. So you see accumulations of the plaque is a cause for inflammation. So you want to do the braces treatment on this kind of patients. The key is the oral hygiene. So without good oral hygiene, then rapid destructions will happen. So adult we reduce but healthy periodontium. Then after that, there's so many ortho come into the discussion. There's an extensive orthodontic tooth movement can be carried out without further periodontal damage. What I'm trying to say is you can do braces treatment on these kind of patients without any further damage, provided the oral hygiene is controlled, is under control of the plaque. Then tooth movement did not result significant further loss of attachment. So even if you do the braces, you're moving the teeth around, then it doesn't cause more further loss of attachment. But if you do it on the adult without a healthy periodontal tissue, let's say the oral hygiene is not good, then the periodontal problem is not controlled, they may experience further breakdown and the tooth loss during the ortho treatment. So if the oral hygiene is not good, then periodontal compromise, then if you're not careful, if you put the braces on it, it might pulling the teeth out from the bone, which is quite dangerous. So you want to do braces, always control the period problem first before you do it. Okay, so what's the real story now? So the pre-treatment evidence of the period tissue destruction is not a contraindication to braces treatment. You still can do it. You still can do it. It's not a contraindication. So orthodontic therapy improve the possibility of saving and restoring the deteriorated conditions. So you can improve the quality of life for these period patients. Like I say, you can close the gap, you can open up the gap, redistribute the space, then sometimes you can extrude the tooth. This will help the patients to improve their functions and aesthetic also. So the risk of occurrence of an active teeth disease process is not increased during ortho treatment. You see, even though this patient have the periodontitis, then if you do the braces treatment, it doesn't mean you're going to make more trouble for these kind of patients. So adult ortho patients are at a higher risk than adolescents for tissue breakdown. So generally, we're thinking about adult and adolescents, which is mean the teenagers. So if we do braces on these two type of patient, two group of patients, usually the adult patient will have a higher risk for the tissue breakdown or periodontal support breakdown compared to the teenagers, which is younger. So the concept or the rationale or the explanation is very simple, because this adult, our recovery ability is not that good compared to teenagers. So teenagers usually can recover better. So the teenagers, the gum and the periodontal support can withstand the forces from the braces a bit better compared to the adult. But do remember, the adult, they are more effective in removing the plaque in orthodontic treatment, which means the adult, they are more disciplined compared to teenagers. So we all know the teenagers, they are not that disciplined compared to the adult, but not always, not always. But generally, the adult, they are understandable, then usually they will be more keen to treatment and they maintain better oral hygiene compared to teenagers. So if you're taking these two factors, they're contra on each other. So we'll say adult and teenagers, they're both also okay to do braces. So adult can brush better, teenager compared to teenagers, but teenagers, their soft tissues or the periodontal support is better compared to the adult. So give it a bit give and take. I think both were equal in the braces treatment. So what's the key element in ortho treatment of adult patient with periodontal disease is eliminate or reduce the plaque accumulations and gingival inflammation. So if we can control the plaque accumulations and the gingival inflammations, then you're going to have a successful treatment. That's the key. So you have to reduce the plaque accumulations and control the gingival inflammations. If this can be done, then braces is okay for periodontal disease patients. So even though for healthy patients or young adult or teenagers, even without good oral hygiene, then you're going to have a periodontal problem. The gums slowly be swollen, then slowly they'll cover the braces, as you can see on these top pictures. So after you debond the patients, they maybe have some mark or the caries or decay. Then even you have some periodontal tissue breakdown. So can we do braces on these periodontal compromised patients? Yes, we can do it, provided we can control the plaque accumulations and the inflammation of the gingiva. So you can see in these pictures, the lower incisor are severe recess, then the periodontal support is compromised quite a lot. So this one is very mobile in the beginning, but after we send it to the periodontist, you can see the tissue slowly back to the normal. You see the color and contour, they're okay. Then the tooth become firm again. So this kind of patient, yeah, we can start patients with the braces. We can start braces treatment on this kind of patient, provided the periodontist can do a good job to control the plaque accumulations and the tissues is back to the normal before we start the braces. So what is the prerequisite to a treatment is met? So before you start any braces treatment, so the patient must have a good general dental awareness, then must be motivated, then the expectation of treatment might be realistic. They're not going to get an ideal treatment result, but acceptable. Then cooperation is very important. If the patient not going cooperative to control the oral hygiene or to control the plaque accumulations, then a lot of bad side effect will happen. We're going to show you later. So then the health tissue status. So assisting this destruction of the tooth and support. So this one you need the X-ray. Before we start the patient treatment, then we need the OPG and sometimes periapical X-ray just to verify their periodontal support. Some are not suitable for braces treatment. If you only left the apical 1/3 holding the tooth in positions, then maybe this kind of patient you have to be very careful. If you do a high force or putting a strong wires on the tooth, then maybe the tooth will not survive. So before you do any braces treatment, you have to evaluate the periodontal support around the tooth. Then ability to achieve and maintain the overall good oral health. So this one again, the key factor is control. Control the plaque accumulations and good oral hygiene and no gum inflammations. So what's the two movement you can achieve by braces treatment? So before you start treatment, after you take the X-ray, then check END, then finance a treatment plan. So you have to consider what type of total movement you want to do for these patients. So every patient will be different. So I would say tipping over bodily movement is more appropriate. Because tipping movement, as you know, you need less force to do it than bodily movement, you need a high force to do it. So the smaller force you put on, then it's less harmful to the tooth. So if you put a heavy force, then you do bodily movement, sometimes you are not careful, you might loosen the tooth too much. So keep it to simple mechanic. So for periodontal compromised patients, then you always go for the simple treatment plan. Then simple treatment plan, it means simple mechanic. Occlusal considerations. So you have to see the patient, sometimes they have so many teeth extracted. So you have to consider the occlusal or the occlusions. So what's the space available? Then sometimes can be drifting of the other teeth into the space. Then the space is not ideal. It can be present or absent of the teeth. Then I say there's so many teeth, multiple teeth have been extracted. Then the position of the opposing tooth. So a lot of time, these patients tend to delay for the restoration of prosthetic work. So a lot of time, this upper or lower teeth can be over-erupted into the space of extractions. Or sometimes the adjacent tooth might be tilting into the space. So a number of teeth to be moved. So if you want to move a lot of teeth, then it's best to use a fixed braces rather than removable. If you just want to achieve this simple tipping movement of the incisor, closing the gap by tipping the incisor back, then maybe removable with a Hawley retainer or the labial bowl, then it is good enough. So we know periodontal support a compromised patients, then they have a bone loss. So bone loss, it means have to reduce periodontal ligament support. Then the same force might produce a greater pressure on the periodontal ligament of the periodontal compromised tooth than the normal support tooth. Okay. Then therefore the magnitude of forces must be reduced in the periodontally compromised patients to prevent the further damage to the periodontal ligament, the bone, cementum, and the root. So I think we talked about this side effect for braces. We will damage the root by shortening the root. Then sometimes if the patient doesn't have a good oral hygiene, then you can cause more damage to the gum and the periodontal support. So the gum recession can happen, then the root shortening can happen, which makes the support is compromised. So the greater the force or loss of attachment, let's say they have more periodontal damage, then the smaller the areas of the supported tooth, then the more apical the central resistance will move, then the greater tripping movement. So you can see from these pictures, so it just show you that the central resistance will move up when you have a periodontal support is compromised. So you see the bone resorption will cause this central resistance moving up to the apical. So when you apply the same force, then for the periodontitis patient, it causes more tipping movement compared to the adult, healthy patients, which will cause bodily movement. So what's the type of appliance you can use? If you always consider removal first, because removal usually they're less or lighter force than compared to fixed. So removal have an advantage over the fixed in case of the multiple teeth are missing. So why? Because this removable, you can put a prosthesis or false tooth or acrylic tooth attached to this acrylic plate or the base. So you see in these pictures, so I got missing one tooth. Then I got some space in the middle. So it can be the false tooth or prosthesis on the one tooth, then link it to the Hawley retainer, the acrylic base on the palatal. Then you can use this as a space maintainer. At the same time, you can use it as a denture temporary whilst you're closing the gap. So fixed is when you want to move the teeth in 3D. So you want to move the teeth up, down, forward, backward, then buccally, lingually, then this kind of movement, you need the fixed braces to do it. So simple tipping movement, you can use removable. When it comes to bodily movement, then better use the fixed braces. Okay, so now we come to a little bit of case discussions. So you see this patient, okay, I think everyone agree with me, this is a patient with a periodontal compromise. So you can see the central incisor, you can see the central incisor, there's so much of recessions. Then if you see the palatal also, there's a lot of gum recessions. then the two is falling apart. You can see there are generous spacing. So why patients with periodontal compromise, then they have generous spacings on the upper and lower teeth? That's because if you look back to these pictures I showed you just now. Okay, so the two must be in the balance force from all the components, top, bottom, front, and back. So let's say you have a periodontal compromised patient, means this two is not strong enough. So the tongue can push the teeth forward. That's why they're causing the spacing on the front teeth. Okay, so you see these pictures? Oh, you see these pictures? Generally spacing on the anterior teeth because the tongue will push the teeth forward. Same with this patient, you can see general spacings on the upper incisor and the lower incisor. So these patients, we only put the upper simple removable braces, then we close the gap, and after that we put the fixed retainer to maintain the result. So the reason why I put the fixed retainer, because for the periodontal compromised patients, high chance the teeth will relapse. Even one day they are not wearing the retainer because the tooth is loose, they are not strong enough. So without this fixed retainer, if you're not wearing this removable retainer, even one day, the space might open up a little bit. So usually for periodontal compromised patients, I give them double defense. First is the fixed retainer, then second is the removable. So double defense to maintain the space closure. So if you see the upper right tooth, this incisor, then after we bring it back, then the periodontal tissue surrounding, periodontal tissue is better. From the severe gum recession, then become a bit better. So braces sometimes can improve the periodontal health. But the bottom, I don't know why the patient went ahead and do the bridge. This one I think is not my plan. But patient choose to do that. So I think patient with a severe periodontal problem, then maybe they are not suitable for the bridge, because the bridge might make it more difficult for the patient to clean the interproximal area. So I think this bridge won't last you for long before it fails. So the sequence of treatments when it comes to periodontitis patients, then the phase 1 treatment is always control the disease, periodontal disease. You need to control the active disease, then you have to control the caries or cause this amalgam composite filling, then can help. Then oral hygiene, scaling, curettage of the or root planning, or gingival graft sometimes by the specialist. Extractions for the pro prognosis too. The endodontic treatment for the tooth can be safer. So you still in good prognosis, part exposed, you try to save it. So when you control this patient's active disease, that's not enough. You have to review the patient, evaluate the patients until the oral hygiene is satisfactory. So sometimes a lot of dentists or general practitioner, they send me the patients with the poor oral hygiene or periodontal compromised patients. When I send it back, then a lot of time they do one-time scaling, then they send it back to me. When the patient come back to me, they're still in the poor oral hygiene, which is not good because I still cannot start a treatment for the patient because the disease is not controlled. So you see, no matter how many times we clean the teeth or do scaling or curettage or root planning, it's not going to be useful without the patient cooperation. So patient have to do their job. So doctor will help you to clean, but the maintenance patient have to do it themselves. So without this maintenance job, then nothing is going to be happening. So these patients, if you come to you, first thing you have to control the disease. Then after that, you have to review the patient, then make sure they can control the disease by themselves. Then after that, then we can consider a more complicated treatment, which is braces, bridge, or even implant. So when you control the patient disease, then we can consider orthodontic tooth movement. But at the same time, when you start the braces treatment, you have to make sure the patient continue the periodontal control. So either by the patient itself or by the doctor, or sometimes both. So it doesn't mean you start braces, then the periodontal treatment is stopped. No, periodontal treatment have to continue even though throughout the braces treatment. So I would say the plaque control or the periodontal treatment have to start before treatment, before auto treatment, during auto treatment, and after auto treatment. Never stop, continuous. So after you achieve the auto treatment result you want, then you have to put a retainer to stabilize the two positions before you go for restorations. Then after you stabilize the two position, then you can consider parasurgery, which is done by the periodontist. They can open the flap, then augment the bone level on the shape. Then sometimes you can do some soft tissue graft or recontouring if necessary. And after they control this perio disease, then you can send for the restorative department. They can do crown bridge or sometimes even implant. So you see, the first treatment is always control the disease. So auto only come later, provided the disease is controlled. So auto, remember, orthodontic treatment or braces only can be done on a healthy tissue. If you're not healthy, don't do it, because you might extrude or exfoliate the tooth by orthodontic treatment. So what's the important point to remember during the active orthodontic treatment? You have to remember orthodontic tooth movement in the presence of the inflammation can lead to rapid and irreversible breakdown of the periodontal tissue. So we all know that gum recession is not reversible. So once it happens, you have to accept. And sometimes, if the periodontal is good enough, they can do the soft tissue graft. Maybe you can regain a little bit of periodontal tissue. But this bone resorptions usually irreversible. So if it happens, then you have to accept. So orthodontic treatment may be in the presence of inflammations is not suitable. It can lead to the rapid destructions of the periodontal tissue. So periodontal therapy is to be continued during orthodontic treatment. Like I said before, you didn't stop the gum treatment or even the root planning or periodontal treatment. You continue doing that even throughout the orthodontic treatment. There has been shown that the regular professional cleaning and curettage might stop or even reverse the destruction of periodontal tissue. So a lot of time, these patients, what happens is, before they start treatment, they're okay. They can maintain very good oral hygiene. They show a positive sign. And okay, everything okay. Then when we start treatment, then the patient back to normal again. They cannot clean very well. Then what are you going to do? You send it back to the general practitioners, or you send it back to the specialist. You stop the auto treatment. You didn't do any active auto treatment yet. You send the patient back to control the gum disease before you restart the treatment again. So if you notice the patient cannot control the oral hygiene, then you stop the treatment temporarily. Then send it back. Then once it control, then you restart again the treatment. You see, auto treatment or braces treatment only can do on the healthy tissue. So always remember, if they're not healthy, send it back, get it healthy, then before we start the treatment again. Very important, very important. So what happens if the patient cannot control? After even send it back to the general practitioner or the periodontist, then we cannot control the oral hygiene. Then we stop. Then we remove the braces. That's it. Patient have to accept the compromised result or the unfinished treatment result. Yeah. So that's a case we did in government practice. So this one, before we start the treatment, of course, we take the study model, then we take the x-ray, then as a record, then we assess the patient periodontal health before we start. So even though this patient have the Bimax proclinations, but we're not going to do the 4 extractions because the periodontal support is compromised. You can see the central incisor space, then they have a gum recessions. Then you can see the periodontal support. They are less than 1:1. So I always tell the patients, so the periodontal support for the root and the crown, the ratio must be 1:1 minimum. So if your head is longer than the tail, then it's not going to be strong enough. So of course, the longer you have, like for example, you have a canine, the head to the tail, the ratio maybe is 1:1.5 or 1:2, then that is a strong tooth. So if you look at those teeth, then the weakest will be the central incisor, upper and lower, because they are single rooted, and they are short root. So those teeth usually they are not very good to withstand the forces from the braces. So these patients, we're going for the compromise result. We're not going to extract the 40 to bring the incisor back. So we're just going to close the gap for these patients. It's a simple treatment, simple treatment. So how are we going to do it? Okay, of course you can do some wax up, or we can do some KESLING setup. Oh, so don't ask me why it's called KESLING setup. Oh, because the name of the person who invented this is called KESLING. So you want to be famous, huh? Something you invented under your name. If you love the country, then you put something under your country name, so everyone remember. So you see this wax up, it's just to simulate the final result for the patients. So patient can visualize it. I can visualize it, then patient can visualize it. So you can take out the tooth, then use the wax, then they'll put it back into the arch, just to simulate the final result. So you show the patient that's the final result, then you can show the periodontist, then there's a final result. Everyone happy, agreeable, then achievable, then we go ahead, we start the treatment. Okay, that's the final result after you finish. So you see, we can always compare the KESLING setup or the waxing before and after. They look quite similar, That means the objective has been achieved. So of course, sometimes I put the fixed retainer at the bottom just to maintain the result. So of course, double. Second defense is by the removable. So you can do the first defense, removable, fixed retainer. Second defense, removable. Okay, so second case, you can see this patient have crossbite on the left, which pushing the lower incisor and the canine forward and to the sideway. So in long term, this one might damage the upper and lower teeth. So nobody care until this upper incisor has been loosened quite a bit. Of course, a bit of plug control is not good. There also can be a contributing factor. So this patient also, we do just simple treatment. So we correct the crossbite, then closing the gap, then we put the patient under maintenance. See this, after you close up the anterior gap, then always we put something to maintain the space. So you can see this removable, then with the prosthesis, temporary to fill up the gap while patient waiting for the restorations. Okay, again, this one you see the canting. Without opposing tooth, then can be over erupt and causing the deep bite. Then we can use the braces to intrude. So when it comes to 3D movement, so these patients, I think it's better to deal with the fixed braces. So you use the fixed braces, then to intrude the upper incisor, then restore it back to the normal occlusion. Then the restorative department can do a better job on the fillings. So imagine if you don't do braces, you just want to cut the tooth, then doing the crown, you're going to end up part exposed. Of course, the result not perfect. Like I say, when it comes to periodontal compromised patients, then we go for simple treatment, then acceptable result, but not perfect. Okay, so this patient also same thing, has a periodontal support compromise. Then we have this central incisor, which is lingually tilted, and it become very loose because of the part accumulations, and patient cannot clean it very well. So we decided to take out the central incisor rather than the premolar. So of course, the top one I take out 2 premolar, the bottom I take out 1 central incisor. So at the end, you end up 3 incisor, then plus 2 missing premolar on the top. But the result, okay. Not perfect. Center line, of course, they're shifted because you have a uneven 2 number on the top and bottom. Of course, I always support the patient with 2 defense. First one, fixed retainer, then second one, removable. Okay. You see, after you remove the central incisor, then straighten the teeth, then the periodontal condition is under control. Okay, again, you see this one, the central incisor, like I say, they are always the weakest. When it comes to periodontal support damage or destructions, then the central incisor always the first one to be compromised. So you see this lower incisor, they're so loose, and the periodontal support is so much damage until you can see almost the root tips. So there's no point keeping this central incisor. So I also decided to remove the central incisor. Then the top one, I take out 2 premolar. Same with the first case. So when it comes to difficult case, then we always remove the poor prognosis tooth rather than the premolar. If the perfect healthy patients, then a lot of time we remove the 2 top, 2 bottom premolars. So when it comes to periodontal compromised patients, we always extract the poor prognosis too, rather than keeping it. So it's no point keeping the central incisor, so we extract it. Of course, at the end, the center line is not perfect, but acceptable. Okay, what happened if you didn't control the periodontal disease? You just keep going with the braces treatment. That is going to happen. You see, the tooth is already exfoliated by the braces or extracted by braces. So this one, we call it orthodontic extractions. It's not a good term, but it can happen if you're not careful. So you keep applying heavy force on that particular tooth, which is periodontal compromise. So after a few years, the tooth might come out. So you see this periodontal tissue is already damaged. Then they have the gum inflammations. Then even they have the abscess due to this tooth is already dead. But no one pay attention to it. So if you see the abscess, you always suspect there's something not right. Take an intraoral PA just to see what happened. So if you have this active disease, what are you going to do? Like I say, you stop the treatment, send the patient back. If you cannot do it yourself, you send it to someone better to control the periodontal tissue health. Then when they are back to normal, healthy tissue, then you restart the treatment. Like this patient, you see the bracket position is so high up. How can a patient clean the gum? There's no way the patient can clean the gum. So what I do at the end, I remove everything. For these patients. Then as we control the periodontal health, then we didn't restart the treatment. We just leave it as is. Then we use a composite to build up the central incisor. So of course the result not perfect, but at least the patient still can keep the teeth. So remember, if you want to do braces, always on the healthy tissue. If they're not healthy, fix it before you start or continue the braces again. So of course there are some other issue. They are not really a severe periodontal compromise. It's just that because the teeth is tilted, they are missing 7, missing 6, then the teeth are tilted forward, 45 degree, 30 degree, 20 degree, then causing this back triangle, huge back triangle, which tend to have their foot stuck in between the embrasures or in the embrasures. So this kind of patient, we can use the braces to upright the tooth. Well, when the tooth is vertical or the parallel to each other, then the triangle will become smaller, then easier for the patient to clean. At the same time, the vertical load will be better because they're vertical. They can transmit the force directly to the root compared to the tilted. If they're tilted, all the heavy force will on the crown rather than the root. So in long term, they might cause more periodontal damage. Same thing, tilted molar, we can upright it, no problem. You can use braces to upright it, but it just takes time. Same thing, if you're missing 7, then the impacted third molar might become useless. So you can upright it, straighten it, closing the gap, then achieve a better periodontal health. Okay, so we finished the first session, which is a periodontal compromised patients. So before we proceed to the next section, then maybe we just ask some questions. So is a periodontitis is a contraindication for ortho or braces treatment? Can we have a cross lab?
No, if it's well controlled.
Very good. So provided it's controlled, then we can do ortho treatment. So what is the key factor for perio patients to undergo ortho treatment? So what's the key factors? So you just give me a few. Can we have Andrew? No? No, Andrew? Can we have Peter?
Control plaque accumulation and gingival inflammation.
Okay, good. Control the plaque accumulations and the gingival inflammations. So that's a key factor. Control the disease, then everything will look good. So could orthodontic treatment causing more destruction to the perio patients? Can we have Jasmine? So anyone want to give a try? Could auto treatment causing more disruptions to the perio patients? Can it happen? Any taker?
Yes.
Yeah.
Yes, it can happen.
Yes, can happen. How?
Yeah. If
It's not answer. Why is that?
if you apply the wrong type of tooth movement,
Okay. Wrong type of movement. Why is the wrong type of tooth movement?
say you apply more force than is required,
Yeah, heavy force can cause disruptions. And what else? Again, if the active disease or the disease not controlled can cause a lot of destruction, rapid destructions, fast, happen too fast until you cannot react. So sometimes even one visit, 1 month later, you can see the gum recessions or the tooth is mobile, mobility is too much to handle. So this can happen very fast if the tissue is not healthy. So this third question, I will say yes or no. If the tissue is healthy, the disease control, then orthodontic treatment shouldn't causing more destructions. But if the disease is not controlled, yeah, we can cause more harm than good for the patients. Okay, I think for the first sessions, I think we finished perio-compromised patients. Any questions? Before we
Yes,
proceed?
Doctor.
Yeah, go ahead.
Okay, because our research topic was related to orthodontics also. So when we were preparing for the introduction, we came across this particular article that states that for self-ligating versus conventional of the ligation system,
Yeah.
one of it will cause more plaque accumulation and the other will not cause so much. And there's also some of the controversies between ceramic and metal brackets of plaque accumulation. So, Doctor, what is your opinion on this?
Okay, seems like you are the expert. You tell me what's your opinion. What's your opinion?
Not my opinion, but based on the articles, it was said that self-ligating doesn't really accumulate that much plaque. But the ceramic versus metal one is still an ongoing debate. So I just am very intrigued with this.
So why this conventional will accumulate more plaque? Because of the rubber they use, is it?
Yes, doctor, I believe so.
Okay. So I think this one is controversial. So debatable also. So if you're talking about rubber and compare the metal surface, of course the rubber accumulate the plaque easier than the metal surface. So metal surface is shiny and they're smooth, so you can brush better compared to rubber. Rubber, after a while, they absorb the water, they oxidize, then they may become a bit more plaque accumulations compared to metal. I think that's the arguing part. But yet remember, this cell ligating, how they work. They have a gate or the clip to open and close every time you put the wires in, isn't it? So once you start closing the clip or the door, then the foot can stuck beneath the door. So sometimes they're stuck until the gate or the clip cannot be opened. So I have a different opinion. I would say if you're not brushing the teeth well, both also could cause problem. There's no easy way out. So self-ligating or conventional, if you didn't brush well, then the plaque will accumulate. Whether they're self-ligating or conventional, to me, it's the same. That's my personal opinion.
Okay, thank you, Dr. Ma.
I think in the future, if you have chance, you can try the self-ligating yourself. Of course, the famous one is Damon. Then we have other brand, Empower Innovations. So many design, even from China, because the patency is over. So they copy the Damon design. There's so many brands in the market. But one common problem for this self-ligating is the foot stuck on the door or the gate until you cannot open it. So sometimes if the plug or the tartar or the calculus start building into the bracket, it cannot move the teeth at all, even for this self-ligating. So conventional, on the other hand, they're easy to clean. Why? Because they have the door to close. When you close the door, you get the foot trapped beneath the door. So this one, I think, if you ask me, I still personally prefer conventional. compared to cell ligating. Of course, I can be biased. I can be biased. You have to try yourself before you can decide which one is better. Yep. Any more questions? If no, then we continue our second topic today, which is the orthoprosto. So how the orthodontist or orthodontic treatment is going to help your prosto colleague? So we can help the prosto or the resto colleague in space redistributions. It means the space is not ideal. Either they're too narrow, then they're too wide, which is not suitable for resto in 1, 2, or sometimes they're just not ideal. Either they're too small or too big. So you have to close it with braces to achieve the ideal space. So you can restore a nice size and the shape of the prosthesis for this patient. So we are talking about space redistributions. We are talking about in 3D. You can move the teeth anterior posterior. I can move the teeth buccolingually, and I can move the teeth vertically. So usually vertical, it means over eruptions. I can intrude the teeth back, and so you can put a crown or implant on the lower or the upper arch. So space closure, sometimes you have a missing tooth, I can close it, or you have too wide the space, then I can close it, become a bit narrow, which is ideal for 1 molar or premolar size. Of course, when you have a missing tooth for too long, the teeth, the adjacent tooth, can tilt forward, then which make your restoration difficult. So it's not ideal. Again, you want to cut the crown, then you might expose the root. So braces can upright the tooth or changing the angle, then to make the two parallel to each other, which is easier for your crown preparations or even implant preparations. Of course, I can move the teeth or tilting the teeth back and forth. I can tilt the crown, and at the same time, I can tilt the root. So we all discussed before, if you're tipping the crown, it's called tipping. If you're tipping the root, then it's considered talking. Talking, two different things. Changing the bite, open bite, deep bite, I can change a little bit. That is a severe one, then you need the surgery to come in. Okay, so same thing again, almost similar to the perio patients. We need a joint planning for all patients because this one involves a few specialists. I'm not the one to restore the tooth later. So I need to communicate well with the the restorative department colleague or the prosthodontist. Then they will decide what they want. They will tell you how many millimeter space they want, then before you start the treatment. So this one had to communicate very, very well. Because at the end, if I can't restore the tooth, then the restore department will bring it to me. So that's why we have to document it very nicely. How many millimeter you need, then what kind of processes you're going to put later. So we start the pre-orthodontic preparations. Again, this one you can do some wax up. You can do some study model, wax up, then before you finalize the treatment. Then if everyone agree, then we start treatment, orthodontic treatment first. Then after that, before we take off the braces, let's say I prepare the space for the restore department. Then before I remove the braces, I bring the patient back to the joint clinic, let them have a look, see whether they're happy with the space. Let's say you think, oh, the space is too narrow, maybe I want a bit wider, about 0.5 millimeter. Then I go back to my clinic again, I open up the space for the patient a bit more. Let's say you think the space is too wide, and you want to close it 0.5 to 1 millimeter, I can do it again. So before I remove the braces, I always bring the patient back to the joint clinic, or I send it back to the restore department. Then let the specialist have a look. Whoever is going to restore the tooth, they will decide whether the space is sufficient, perfect or not. Then after that, if they're happy, then I will remove the braces and put a retainer temporary to maintain the space while the restore department restore the tooth, whether we're using a prosthesis or the fixed prosthesis or removable, or even implant. So you see this on joint clinic first, then everyone decide the treatment plan. Then ortho usually always the one to start first. Then after that, review by us specialists. Then once they're happy, remove the braces, then put the retainer, then holding the space. Then the restore department will put the bridge, crown, or even implant on that too. Okay, so we're going to talk about this very common thing, which is a maxillary lateral incisor missing. Missing 1, 2, or 2, 2. So if you go back to the lecture I gave before, then you know the most commonly missing teeth is upper 2, lower 5, and even the third molar. But the third molar is not included in our treatment plan, so we're not going to talk about it. Then we usually have to deal with the missing lateral incisor and the missing premolar most of the time. So today I'm just going to talk about this topic, missing lateral incisor, how we're going to deal with that before we consider restorations. So we know there's about 1 to 2% in the populations. Then a treatment option can be space closure. You can close the gap if you want to. This lateral incisor, you can close the gap. Or you can open this gap back to the perfect space, 1 gap, 2 gap, then restore it with the prosthesis, either implant or bridge. So when to close the gap, when to open the gap, then we're going to talk about it. So before you want to decide you want to close the gap or not, then you have to remember, if you close the gap, you're bringing this canine into the lateral incisor position. So you're using the canine to substitute this lateral incisor. So you have to consider your malocclusions, whether they are class 3, class 1, and class 2. If the class 2, maybe you can close the gap, you can retract the incisor. But if the class 3, let's say you retract the incisor, then you become reverse overjet, which is not good. So you have to consider the malocclusions. Of course, the profile, you have to talk about the lip posture or the profile. So if you retract the incisor too much, then the upper lip can be flattened quite a lot. So profile, you have to consider also. Then the thing is the canine shape and the colors. So we know the canine is a bit wider than average, about 9 millimeters, medial distal width. Then they're also a bit higher. If you compare the gingival height, then the canine is almost the same with the central incisor. So when you position the bracket for this central incisor, lateral incisor, and this canine, we always remember this high, low, high. Look like a foul language, but it's not. It means we just make the incisor a bit longer, central incisor longer, then lateral incisor a bit shorter, then back to canine a bit longer. So we call it high, low, high. So you see this, if you put the canine next to the central incisor, the first thing is the canine will look flat. They don't look like the natural lateral incisor, which is quite narrow. So the canine can be fat, and it can be long, and it can be bulbous a little bit on the labia and the palatal surface. And at the same time, the shape is different. They're sharp, they're franky and sharp. So a lot of times, if you want to close the gap, you bring the canine into the lateral incisor position. You need to make some modification to the colors, the shape, and the size. Then you have to consider the lip line also. So let's say the patient have a high lip line. When they smile, you can see all the incisor and canine. Then it can be quite obvious. This canine can be quite obvious to look next to the central incisor. So if the low lip line, let's say the low lip line, then everything will cover. They hardly see any gingival margin. Then there will be a good case to put the canine next to the central incisor, because the lip, if they're not high enough, you cannot see the gingival margin. It's good case for camouflage. Of course, the canine morphology, like I said before, they can be a bit wider, medial distally. Then if they're a bit wider, it can cause overjet issue. So if they are narrow incisor, lateral incisor, which is about maybe 7 millimeters or sometimes 6 millimeters. So this one, if the canine is bigger, 9 millimeters and 10 millimeters, then the teeth will stick out a little bit, because the size on the upper teeth is bigger than the lower teeth, because of overjet issue. And if you're talking about the convexity of the palatal surface, you know the incisor, the surface on the palatal is different from the canine. Canine usually a bit more bulbous. So if you have this canine, the palatal surface different, can cause overbite issue. Then gingival margin, like say the low lip line and high lip line. So you have to consider gingival margin. So sometimes we purposely extrude the canine, bring the canine down a little bit, so to make the gingiva similar to the lateral incisor. So we know the canine Usually, the gum margin is almost similar to the central incisor. So we extrude it, then we make the gum margin a bit lower. Then later we trim the canine, become a bit shorter, just to mimic the lateral incisor. Then the colors, then usually the canine, they look a bit yellowish. They're more saturated colors. So compared to lateral incisor, which is whiter, so you have to modify the color sometimes. If the very yellowish canine, you put it next to the central incisor, they can look bad to the patients. So a lot of time when it comes to color difference, first thing you can do some whitening. Hopefully you can achieve the result you want. Then some more aggressive colleague, they might just grind the two. Then they put the layers of veneer on top. Then you can change the size and the shape at the same time. And the color as well. So when we close the gap, so obviously when the teeth is sticking out too much, then you've got so much a gap, then you consider closing your gap and retract the incisor back, which is typical case for the class 2 division 1. You have an increased overjet, then teeth sticking out, then you want to close the gap, bringing the incisor back. This kind of case is suitable for the space closure. So you can close the gap, you can get a better overjet. Then crowded labial segment. So let's say it's not enough space for the central incisor and sometimes even up to the canine and the premolar area, then you can use the space to relieve the crowding. So this kind of case also, crowded cases, then you can do space closure. So before you decide to close the gap, of course you have to do the important considerations, the canine width, the size, then the gingival height, smile line, everything comes into considerations. Okay, what's the typical case? You have to open the space. You decide not to close the gap. So class 1 patients. So let's say everything is class 1. Canine class 1, molar class 1, incisor class 1. Then it's better to maintain this space. Open it up, then replace with a prosthesis or implant. Because if you start closing the gap, then from a class 1, you become a class 3 or even reverse overjet. Because the teeth will be retract. Central incisor, once it retract, the overjet can be compromised. Class 3 incisor relationship. Class 3 always open the gap because you don't want the upper incisor to come backward further. It cause the reverse overjet even worse. Unless you're going to do the orthodontic surgery, okay, you can close the gap. Otherwise, you want to camouflage, you have to make sure the incisor, upper incisor is biting in front of the lower incisor. Then it's better to open up the space rather than closing the gap. Space labial segment. Let's say there's so much of space. Then if you close it, then it might not be stable. So like the slide we showed you before, the teeth might be need to be into the spacer, into a stable position, which is from the labial, lingual, and upper and lower. So this force must become the balance to maintain the two interpositions. So if you close a gap, such a big gap, a lot of times they are not stable, they tend to relapse. If you're not wearing the retainer even for a few days, then the space can open up a little bit. So if you're closing such a huge gap, then a lot of time you need the fixed retainer to come in to maintain the result. So space labial segment, then a lot of time we open up the space, then replace it with the implant or bridge. Okay, so that's for the lateral incisor. So lateral incisor can two options. Either you close the gap, you open the gap based on the mount occlusion itself. Then at the same time, you have to do some special considerations on the crown width, the mesodistal, vertical, the gum margin, and the colors of the canine. So these have to take into considerations. Okay, so now we look at some cases example. So for this case, you see we have too much a gap on the lower labial surface, labial segment. So central incisors, the gap, but this patient also maybe have an overjet issue. So before you want to restore, and you maybe want to redistribute the space. So this one, you want to close the gap on the lower, then maybe you have to do a log composite, mesodistal, or log composite, or you can put one crown or the bridge in the middle. So after discuss with the professor on this, then we decided to open up the gap because if you close the gap, then maybe you have an overjet issue. And this patient doesn't want the top braces, so you just want the bottom braces just to redistribute the space. So usually upper braces quite obvious, and lower braces not too bad, not too bad. So this one, we put the braces on the lower, then we push the central incisor apart, the lateral incisor and central incisor. Then we open up the space to one incisor. So then the prosthodontist can come in and restore with the resin bonded bridge or Magellan bridge. So this one is called space redistributions. Okay, then after that, then they put the denture because this patient have multiple missing teeth. So we put denture on these two quadrants. Of course, sometimes if you extract 1, 2, you want to close the gap, you don't want any prosthesis, so braces can help also. So let's example, let's say you extract one pro-prognosis 6, then you don't want to restore it, or you don't want to do RCT or the badly broken, then you can drag the 7 and 8 forward, then using this as a replacement. Of course, they're not easy. Usually take a long treatment, but this one can be done by braces, no problem. Then sometimes if the patient have missing teeth, then deep bite, then you see the angle of the incisors, they're not ideal, they lean back so much. How are you going to restore it? Even when you do the crown, then it's not going to look good. You might end up cutting too much of the incisor enamel and the dentin. You might end up expose the pulp. So on this kind of case, we can help you to change the angle labially, labial and buccal or the buccal palatal. So this time we have to do the root talking and the tipping of the incisor crown. So by changing the incisor angulation, then maybe you can restore the tooth better. You can open up the bite also. Okay, sometimes the space is too big. So this patient, you see, you leave it for too long. After so many years, you see how much atrophy happened. So the bone resorption is very severe. So this one we call it knife edge or narrow edges. So this one is very difficult to restore by braces, by the implant, because there's no bone. So imagine you want to put one implant in the middle, you need the bone to be thick enough or fat enough before you can receive the implant. So this kind of patient, we use the braces, redistribute the space again. I gather all the incisor, closing the gap. At the same time, I bring the molar forward. Then closing the gap to one premolar space. Then the restorative department can restore the tooth better. So at the end, you can end up 2 premolar restorations or replacement, rather than you have a big gap, maybe you need the molar and premolar. So we reduce the number of prostheses the patient needs. So if you see carefully, when we start closing the gap, you see the bone become a bit bigger or whiter. The width increases. That's what we call the ridge augmentations. So of course, sometimes you have a missing tooth, 1 tooth missing, then center line is off to one side. So this kind of patient, again, we can redistribute the space, can open up the space for the missing lateral incisor, and after that, you can replace the missing lateral incisor with a prosthesis, bridge or implant. Then the midline back to the center. That's what braces can do. So this one on the top view, you can see I open up the space, then closing the gap on the left. So one side closing, then the other side opening up the gap. This one we call it space redistribution. And after that, we put the bridge. So this one I think is a resin bonded bridge. So it's a simple one. While waiting the patient to become 18 or 20, then they can do the implant later. So young patient, we tend to hold the gap then before they receive the implant. Because implant, you only do it when the patient stops growing. You don't do it on the active growing patients because the implant position is not stable if they're still growing. Okay, same thing. You see these patients. This patient have a missing lateral incisor. Then someone try to fix the problem. So what they do, they build up the tooth, become bigger. You're using the composite, left, right, then even on the canine. You see how big the canine is? Then this part is the composite. But you look at the midlines, how much are off. So the midlines on the bottom, sometimes they're not important. When you come to the top midline, they're quite obvious. When a patient smiles, you can see the midlines off to one side. And so if more than 4 millimeter discrepancy, then any layman they can notice that. So in this case, then we open up the space. You see, when we open up the retro incisor, then the midline will back to the center. Of course, we need the prosthesis to occupy the space again. Okay, auto restore. What we can do for the restore click. Okay, sometimes the black triangle happen, then maybe we can do some interproximal stripping, then closing the gap. And once you start closing the gap, then maybe you can squeeze the incisor up a little bit. Sorry, squeeze the gingiva up a little bit. Then you make the black triangle less obvious. So that's what braces can do. Rather than you just put a filling in the proximal, which is to know whether they're smooth or not, then maybe sometimes you create some undercut. It causes more gum accumulations or plaque accumulations. Then in long term, it damages more gum, which is not good. So in the proximal filling is not easy, especially when you want to close a black triangle. Of course, sometimes if you leave the tooth for too long, extracted too long, then the upper teeth might become over-erupted. Then make the restoration is difficult. So what we can do with braces, I can use the braces to bring this tooth up again, intrusion. So if they're over-erupted, I can do some intrusion, then bring the molar up. Then after that, the implant or the crown can come in. So these braces can create the gap vertically. This one I use mini screw, because patient don't want braces anymore. So I use the simple sectional braces. Again, sometimes the aesthetic colleague, they are talking about the buccal corridor. So how are you going to settle this? You might stick a very thick veneer, then maybe you can occupy the buccal corridor, or you can use braces. Braces can expand the upper and lower jaw, then make the buccal corridor smaller. That's what we can do without any smile design. So you can achieve by braces. Again, gummy smile, very common problem, especially for ladies. So this one, usually you can do it with the surgery or braces. Braces, you need to put a mini screw. Mini screw can intrude the upper incisor or the whole segment, then to mimic the impaction of the maxilla. But there's a limitation how much you can do it. If it's too severe, I think you still need the surgery to come in. If the minor one, maybe less than 5 millimeters, or even up to 7 millimeters, then braces plus mini screw can achieve the result. So imagine if you want to do the crown or the veneer, how much of gum you need to cut. You cannot cut you cannot cut the gum 5 or 6 millimeters, then make a long Frankie incisor. It's going to look horrible. Again, crossbite, then with the severe attritions, then you cannot restore the tooth. You cannot put a composite filling because it might fall out. So you need to fix the overjet and the overbite before you can put a better composite. So this time we use a simple upper fixed braces, then porcline the upper incisor. Once they have a positive overbite and overjet, then we went ahead and restore with a composite filling. Same thing, let's say you have one incisor, then crossbite. And how are you going to restore this incisor? You can't. So you need the braces to fix the overjet overbite. And after that, you can do the nice filling on the incisor edge. Yeah, so braces can do quite a lot of things. If you want the perfect result, sometimes no choice, you need the braces to help. So that's why sometimes they say the braces is the leader when you come to restorations. When you come to difficult case, then braces is always the leader to determine how much space you can close and open, then before the restorative colleague will come in. So for this case, it's quite special. You can see there's a treated incisor, and lateral incisor, central incisor, and even the canine. So this patient have bruxism case. So if you want to restore the case, then sometimes you need to create the gap. You want to restore the composite on the treated tooth, so you need some vertical height. So we can use braces to open up the vertical height. You can see there's some space between the canine. And after that, we can restore the attritions with the composite again. So this one can be achieved by braces. Same thing, crossbite. You see the crossbite castry, then maybe you want to restore the tooth. How are you going to do it? You cannot cut the crown. Even you can cut the tooth down to the top, or you can reduce the size a lot. At the end, they're not going to look nice because there's too much of crowding. Yeah, not 4 small crown on the anterior. Then you're not going to change the angle, the crown angle too much. If you want to change the angle too much, then sometimes they weaken the root. So in this kind of case, then we use the braces. Again, we correct the overjet and overbite, and let them have a positive bite. It means the overjet is positive, overbite positive. Then before we restore with the crown. Again, lateral incisor, small lateral incisor. You can open up the space. Open up the space, mesial distally. Open a little bit mesial, a bit distal. Then the restore department can restore the mesial distal with the composite. Then patient can have a nice incisor, proportional incisor. So this is a close-up of the incisor. So you can see the peg-shaped lateral incisor. Then we open up the space, mesial distal. Then we put a composite temporary. And after that, we do some crown lengthening, gingivectomy, then plus the veneer on the lateral incisor. Deep bite, I think I told you many times. So deep bite, you always check for the destructions or any occlusal trauma. Then you check the incisor edge, whether they have attritions. At the same time, you check the soft tissue, whether they have a gum recessions. And third, you check for the mobility of the tooth, whether any tooth is mobile because they're heavy force. So this kind of patient, generally they have this attrition problem because the deep bite, they usually grind the teeth a little bit. The lower incisor usually attrited. But with this deep bite, you cannot restore because they are going to create a vertical overbite, or you're going to increase the vertical height quite a lot. So how are you going to do it? We use the braces to open up the bite first. Open up the bite, then when you have a gap between the top and bottom teeth, then you can restore the attritions. So you see the attrition on the lower incisor. That's how bad, right? They almost expose the pop. So this one, you can see the dentin, which is yellow colors. Then surrounding it is a white color, is enamel. So this severe attritions, if you leave it long enough, then sometimes you can expose the pop. But patient have a deep bite, so you cannot put the layers of composite on top of the incisor edge. You're going to cause a high bite. Then patient not going to like it. So this kind of patient, we use the braces to align. At the same time, we open up the vertical height. Then the restorative colleague can come in and do the fillings on the incisor edge. Yeah, you can see the 4 incisor edge is already filled out by the composite. Okay, so you see this one is the same thing, no? Same thing. Look at the incisor edge on the lowers. So they are badly attrited due to deep bite again. So this one you can open up the bite. Then again, restorative department can come in to fill up or to restore the incisor edge back to normal. Okay. Then sometimes if you're not happy with the shape and the angle, then braces can straighten the teeth. Then before your powerful smile design come in. Now I think a lot of doctors going for this smile design, which is started by this style Italian. So they are very keen for this smile design. But sometimes if the teeth is too crooked, then maybe even if you do a smile design, it's going to be difficult. So what we can do a simple braces just to align the teeth a bit better than before they start this smile design. So when the teeth are straight, it's always easier to restore compared to a crooked teeth. Then you don't have to cut so much of the enamel and the dentin. So this one is a good way to avoid invasive treatment for the patient. Of course, missing lateral incisal. I think we discussed before. This one, you can close it or you can open it. So in this case, I choose to close it because you have look at lower. There are two missing central incisors also. So there are two retained decidus, then plus two missing lateral incisor. So if you remember the lecture just now, we talked about if you want to close the gap, then you have to remember that there are some factors you need to consider. The mesial distal width of the canine, then the vertical gingival height, and the colors of the canine. So you look at the colors of this canine, they're not too bad. Not too bad. They're quite similar to the incisor. So I think we are not going to have a big problem. So if this if this canine is too yellowish, then maybe you need to change the color later. So I think it's okay if I bring this canine into the lateral incisor position. Then second thing, you look at the height, the gingival height. They're not too bad. You see the canine, the height is almost same with the lateral incisor, or they're slightly below the central incisor. So by bringing this canine into lateral incisor positions, I think the gum level is not too bad. Not too bad. If this canine have a high gum margin, then maybe it's not suitable. So in this case, I decided to close the gap. So after I close the gap, the third thing you have to consider is the mesial distal width. So the canine definitely will look a bit bigger than the lateral incisor. They're usually about 2 to 3 millimeters extra compared to the lateral incisor. So what I do, I slim down the canine a little bit, mesial distal. So I cut a little bit mesial, a little bit distal, just to make the canine look a bit slimmer. And at the end, we put a composite on the corner, just to make it a bit more squarish, just to mimic the lateral incisor again. Okay, so sometimes the prosthodontist, they send a case, then patient have a failed bridge, then they don't want to keep this bridge, then they want to close the gap by taking out the apartment 2. Sorry, the Pontic 2. So they want to cut this bridge, they take away the bridge, then we can use braces to close it. So at the end, patient can get away without any bridge. Same thing. This one 2 unit, we can close it also. Yeah, no problem. But provided the 2 is strong enough. So let's say it's periodontal compromised, then maybe we cannot do it. Again, back to the basic, whether the 2 is perfectly healthy or not. If they're not healthy, then we cannot do braces. Okay, auto restore prosto finish. Any questions?
Oh,
Yeah.
For the
Yeah.
for the space closure and space opening, you use a fix or removal also works.
What do you think? Closing the gap is considered body movement or tipping movement?
Body movement.
Yeah, body movement, then what are you going to use? Fix, yeah. So this one you need a fix. Because you're not talking about tipping movement. You need body movement, you go for fix.
And for the black triangle, actually I don't quite understand that too.
Back triangle?
Closure, yes. I think
How we do it?
Yeah.
Okay. This one. You see the back triangle, why it happened? Because of the gum recessions. You see the shape is like a big triangle. So in between these teeth, the embrasure is filled up by the gum. So when the gum disappears, then you see the back triangle. Then this, especially for braces patient, which you cannot clean very well in between the teeth, then back triangle can happen very commonly. So how we're going to reduce a back triangle is to cut the teeth. They call it interproximal stripping or reductions. So what we do, we use a very sharp instrument, sometimes a diamond disc, or sometimes a very long taper fissure burr. Then just slide in between the two a little bit. Only on the enamel, not on the dentin. If you reach the dentin, you will cause sensitivity. So what we do is slide a little bit left and right, left and right, left and right, create a gap about 0.5 to 1 millimeters. So when you start closing the gap, then this triangle is going to become smaller. Yeah, as you can see on these pictures. Of course, if the back triangle is very big, you cannot cut the tooth too much lah. You cannot cut in 1/3. You're going to expose the dentin, make the teeth sensitive. So what you can do, you can minimize it, but you cannot get rid of it completely. So big triangle, I can make it smaller, but small triangle, I can make it disappear. Does it answer your questions?
So you mean the space is close because the tooth is more closer to each other, not the gum like more growth, right? In more.
Controversial, this one. First thing is illusions. If you close the gap, then the teeth are a bit closer to each other. That's why the triangle becomes smaller. Then the second effect is they say once you get the space close, then you can squeeze the gum up a little bit. So the gum will climb up a little bit, like climb up the ladder a little bit, then fill up the gap. Can you imagine?
Oh, okay, I see. So,
Yeah.
Both.
Yeah.
Okay.
Because you shift the contact point. You see on this first picture, the contact point a bit higher, isn't it? This is the contact point. So when you cut the two, then you bring it a bit closer. You're actually shifting the contact point to a bit more gingival. So when the contact point go a bit lower, then the gum can go up a bit higher. Yep. I hope that makes sense.
Yeah.
Any more questions?
Doctor,
Yeah, go ahead.
how does ortho help in the gummy smile?
Gummy smile. Intrusion.
But like if it's an intrusion, then
Yeah.
wouldn't it like make it more gummy?
How you make it more gummy? You know, intrusion is when you are bringing the teeth up. Huh? It's called intrusion, isn't it? Intrude into the gum or intrude into the bone. That's what we call intrusion, isn't it? Intrusion is bringing it up into the gum or the bone. Intrusion. This one okay? You see these patients, if I push the teeth into the gum, then the gum margin also will follow. You're not pushing the gum only into the gum. The teeth together with the periodontal structures. So when you push the teeth in, then the gum also will follow. Yeah.
Which means
So,
that if we do intrusion, then the gum will actually like move up hyper as well.
Yeah. The gum will move accordingly to your new periodontal attachment. Of course, sometimes if you do it too fast, the gum might not respond very well. Then the teeth might start sinking into the gum. Then you have to do some gingivectomy to cut the excess of the gum. These are another topic. But intrusions can help the gummy smile. So sometimes, if you remember, I tell you during the lecture of the headgear, if you have the vertical excess, then you can use the vertical headgear, vertical force to intrude the maxilla or impact the maxilla a little bit. That will help your gummy smile as well. But you need the extra oral appliance, which is headgear to do. Or you can do the surgery, just cut the maxilla, and then impact the maxilla, then the gummy smile will go away. That's another topic, alternative surgery. Okay.
Doctor,
Yeah.
for the implant place just now that you mean about the bone, the thin one.
Yeah.
I wonder how you measure the molar come forward and not the anterior come backward.
Oh, then you have to revise your lecture anchorage. Which one is it? Not this one. Prosto. Okay, we are talking about prosto. This one. Is that this one?
Yeah.
Okay. So you have to control the anchorage. Let's say now you want to bring the back teeth forward. Of course, you consolidate all 6 teeth together first. You see, I closing the anterior gap a little bit. Then before I start bringing the molar forward, that's what we call the anchorage control. So you're using the 6 teeth against 2 molar. Of course, sometimes the front teeth also will go a bit backward because you're pulling it. Let's see properly. So sometimes you have to use a rubber band from the bottom to the top. We call it class 2 elastic. Then to help to visualize the molar. So that's all about anchorage control. So I think this one you have to revise your lecture anchorage. Huh? So control the tooth movement. So anchorage control, it means it's just control the unwanted tooth movement. Okay, any more questions?
Doctor,
Yeah,
when you use the canine to replace the lateral, right?
yeah.
Would you, yeah. Then no more canine guidance, is it, for the patient?
Good questions. What's canine guidance?
It is the canine guidance lah.
Yeah, what's canine guidance? Explain to me.
Wait ah.
So exam asks you what's canine guidance, it's just canine guidance lah. Get 0 marks lah. So canine guidance, it means that when you're doing this lateral exclusions, left and right, then the canine will come into contact first. So you use the canine to glide your jaw to the left and right. Then by doing that, then you have the separation between your incisor and the molar. So it's only touching on the canine. So the canine will protect the other teeth when you're grinding the jaw left and right. That's called canine guidance. You try it now, using your jaw slide to left and right. So see whether you're touching a canine first or other teeth. If you're touching a canine only, then you're having a canine guidance. But if you're not touching a canine, you're cutting all the teeth on the buccal surface, premolars, molars, then that is considered group guidance. Group guidance compared to canine guidance. So canine guidance is only one single tooth. Group guidance is involved more than canine. So this is not very important. If you look at the research, of course, if you have a canine guidance, sometimes it's the best. Without the canine guidance, it still survive, no problem.
So when you do ortho, canine guidance is not really your objective lah.
It's something you try to achieve, but if you didn't achieve, it's okay, provided the functional, the function is still there. So canine guidance, I would say, is something I try to achieve. Or sometimes if you want to substitute the canine into this lateral position, then maybe the canine guidance is gone. We're not talking about canine guidance anymore. So we're talking about group guidance. Do I have it? Let me see. Let me go back to the slide. Okay. Okay. So this canine guidance is only when you canine to canine. So when you move the canine to the lateral incisor position, then mostly when you slide left, right, and the canine is touching the premolar. So the premolar become a premolar guidance. So it doesn't matter, even though you have a premolar guidance or group guidance, it still can survive, no problem. Yeah. So canine guidance is something good to achieve, but not necessarily 100% must be achieved. Without canine guidance, it's still going to survive. So what happens is a lot of time people have this bruxism. You can see this canine is grind down quite a bit. So from canine guidance, when you get older with a bruxism, you become a group guidance eventually. Yeah. So young patient, I try to achieve canine guidance. Old patient, sometimes not possible due to the attrition of the canine. Okay, hope that answers your questions. Any more questions? Can't find it. Oh, okay, yeah, this one. Yeah. Okay, if no questions, then I will just proceed to my last topic today, which is oral surgery. So oral surgeon is a lot of time they help us, or they help me rather than I help them. Yeah, it's mostly we are talking about impacted or atopic tooth in a different position, high up in the nose, deep down into the jaw. Then we need to do the exposure plus the gold change or attachment so we can drag it out with braces. So we are talking about the impacted tooth or the adjacent tooth, which is in a crooked angle. So sometimes you can upright it, then the oral surgeon can do the implant better. Or sometimes we can consider rich development, like I show you in the picture just now. Once you bring the teeth together, sometimes you can generate certain amount of bone. So this one is a ridge development. You can see when I start closing the gap from the molars, then they'll become a bit thicker, the ridge. Yeah. So this one we call it ridge development. So the concept behind it is when there's a bone, when there's a teeth, there's a bone. No teeth, no bone. That's why when you extract the tooth, then the atrophy will happen. The bone resorption will happen. So we try to bring the teeth into the resorptions or the knife edge ridge. Then hopefully the two will bring the bone together. So that's how we generate the amount of bone. Yeah? Of course, sometimes they will push the two into the space. Let's say I want to avoid any bone graft. I might be pushing this second premolar into the extraction space. Then by doing that, then this space is going to fill up with bone again. So this one we call it bone development. So of course, impacted tooth, you can put a gold change, expose the canine, then put a gold change, you can bring it down. Even though high up in the nose, you can expose this canine, then put a gold change, then you can drag it down slowly by braces. Provided they're not ankylosed. Ankylosed, if they're stuck, then it not happen. It cannot happen. So impacted canine again. So this one you can expose, then you can bring it down with braces. So you see this one, canine impacted, then with the retained decidus on both sides, you can bring it down with the oral surgeon's exposures of the canine. You can bring it down. So sometimes patients don't even realize they have impacted canine until they have X-ray done. Sometimes a lot of people think this one is an adult tooth. The layman don't understand what is the adult tooth and the decidus tooth look like. But I'm surprised sometimes the dentist also cannot differentiate, which is quite sad. So they've been going to the dentist for many years, but no one pick up. There's a decidus still there. So sometimes if you're not sure, always check with an X-ray. You never go wrong. So again, this one impacted premolars, high up in the nose or sinus, so we can bring it down by doing the exposure past the attachment and slowly bring it down by braces. So this one, same thing again. After many years, no one realized there's a missing premolar until patient have an X-ray done. Of course, central incisor will be more obvious. This one easy to spot. If you fail to spot the missing central incisor, I think you'll fail. You'll fail accent. So this one can bring down by braces. Open up the space, and put attachment. This one will come down. This one is uprighting the tooth. So you see this one have a missing premolars, molars. Then this one have a missing molar. 2 molar missing. This one is the 3rd molar. So you see this one, maybe it's a long span of bridge if you want to do it. So braces can bring this molar forward, 3rd molar forward. Then you can generate some amount of bone. At the same time, you can make a long span become a short span of bridge. So you see this one is tilted angle. You can straighten it by braces. And at the end, then the implant surgeon can put in 2 parallel implants. Yeah. Of course, again, sometimes, like just now, the case over-erupted over-erupted upper teeth or lower teeth, usually the molar. Then there's not enough space to put the implant. Then you can use the braces again to intrude the tooth, then make the vertical height a bit better. So you can put the replacement, implant, bridge, or denture. So same thing, this one vertical height not enough, so you can use the braces. That's a problem. If you have a missing teeth, then you better restore it not too long. If you wait too long, then the teeth will over-erupt, then the bone resorb, then it make everything difficult. So this one, if you are over-erupted, you got no choice. Either you want to cut the tooth, become smaller or shorter, which might expose the pulp, or you can do some intrusion using the braces. Bring the tooth back into the bone or the gum, then you can make room for the restoration later. So this one we are talking about vertical height. Okay, good positioning. Okay, so this one same thing. You want to put the implant on the lateral incisor. So you need the braces to make the root parallel. So if their root is like a wedging effect, then this one you cannot put the implant. So the root positions is very important. You have to make sure they're parallel before you can put the implant in between it. So imagine if the root is not parallel, you put the implant, it might damage the root. So you need the braces to parallelize, to make the root parallel. Okay, sometimes if you have impacted third molar, which is causing the damage to the second molar, then it involves the pop, then 2 deep subgingival caries, then we can consider extract the 7, and then bringing the 8 forward as a substitute or replacement. Of course, this one takes time now. So if possible, if we don't have to do this, how? Take out this impacted canine for prevention. If you notice there's a foot stuck, constantly foot stuck, then causing difficulty in cleaning, then maybe you take it out in long term to prevent the caries on the next 2. Okay, of course, sometimes people might think about the third molar. The only options impacted third molar is to take it out. Braces can straighten it. If you don't want to take it out, then you can straighten it and make it functional again. So the 2 must be in a pair, or the teeth must be in a pair before they become functional. So if they are not straight or they're crooked, then this one is not considered functional. Then braces, you can straighten it and make the third molar a functional pair. Of course, this one I don't do it just for the third molar. I do it because I do the braces for the top and bottom. So at the same time, I straighten the third molar if the patient requested. So you have to intrude this upper, you have to intrude, then only you can have the space to upright the third molar. Same thing, you can upright the third molar. Take time, third molar, you can upright. Not only third molar, I straighten all the teeth. At the same time, I straighten the third molar. Same thing, horizontal also, you can straighten it. You just need time, you need time to do that. Open bite. Traditionally, we have to do it with the surgery, orthodontic surgery, to close the open bite. Now with the braces, we can do it with the mini screw, so we can achieve a reasonable result. So same thing, open bite, and only touching the 7. So we can use the braces plus the mini screw, we can achieve a reasonable result. Okay, so this one is a surgeon helped me to do the gingivectomy. So sometimes after you straighten with braces, the gum didn't respond in a favorable way. So you see the gum margin, they are not even on both sides. So we need the surgeon come in and then do some simple gingivectomy and restore the gingival height to perfect proportion. So this one again is smile design, smile design. Okay, with that, I think I finished all my topic in 2 hours. It's a long lecture. In fact, I want to do a group discussion later, but I think we don't have enough time. I will keep that for the next interactions sessions, which I think should be next week. So there's a file I uploaded in your LMS. It's called Multidisciplinary Approach of Orthodontics. So you download that file. Then I think I speak to your class rep. You have to divide yourself into 3 groups. Is it 3 groups? Then you discuss the clinical finding. Same thing, like we do the E&D, clinical finding. Then what is your X-ray finding? Then after that, give me a summary. Then after that, treatment plan with this multidisciplinary team approach. You don't have to be a periodontist or the restodontist, but I just think what's the best for this patient when it involves so many teams or so many disciplines. Do we have any questions before we end this lectures? So don't worry, don't worry, this one will come out in the exam, but it's good to know because you're going to be a dentist soon. So we don't treat the patient just for the ortho problem. A lot of time the patients are involved so many problems. So you need to have this multidisciplinary team approach to deal with the problem. Yeah, questions? Yeah.
Dr. Mark, for the case just now, where your posterior part, you had a knife edge. Yeah, that one. Then after you do the ortho already, did you do bone grafting?
No. This one is before bone grafting. So you see, when I close the gap, it can make the bone a bit fatter. So by doing that, it might reduce the amount of bone grafting. Let's say in this case, maybe you have to graft the buccal and lingual, then you have to use a lot of bone. When it comes to this situation, maybe you just add a little bit of bone on buccal. So you reduce the amount of bone graft. So if you're lucky, sometimes you don't have to do the bone graft.
Are you saying that after ortho, the width of bone will actually increase?
Yeah, it will.
How?
It's a concept of tooth and bone. If there's a presence of tooth, there's a presence of bone. So you see the bone is attached to the teeth. Isn't it? So when we move the teeth around, then the bone will follow. Otherwise, it might move the teeth in the empty space. The tooth might fall out, isn't it? So when we move the tooth slowly, then it will bring the bone together with the tooth. That's how we do the ridge augmentation. Okay, this one I think if you're interested, you should register for the postgrad ortho. Huh? You can discuss about it a bit better. Because this one is complicated. I need another lecture to explain this. This one is difficult. But you just remember, the concept is the tooth and the bone. They coexist. Without the bone, there's no tooth. Then without the tooth, there's no bone. They must be coexist. So when you bring the tooth into the empty space, then they will regenerate the bone. Same that the cleft patients. If you remember the cleft patient, why we do ABG? Because there's an empty gap in between the bone. So they're not continuous bone. That's why we cannot bring the canine out. That's why I do ABG, fill up the gap. When there's a bone, then only the tooth will come into the space. Yeah. Hope that answers your questions. Yeah.
Yeah.
Okay. Any more questions?
Doctor, I just want to ask for the discussion, should we do now or we do it like next week?
I think we do it next week. I think everyone is tired.
I mean like we do it at maybe we do it with our own group tomorrow or
you can do it during your leisure time. I think this one I just want you to present during our interactive sections.
So we do it next week, huh?
Yeah, we do it next week.
Okay.
We do it next week.
Okay.
Any more questions? If no questions, then maybe we'll end these sessions. So this one is not an easy lecture to understand. It involves so much knowledge behind, but it's okay. We give you a taste of what we can do with braces to help you in general for the patient health. So if you get an idea what braces can do, then you can plan your case better. So even though you're not orthodontist, but you know what braces can do, it's going to help you your daily treatment for the patients. Any more questions? If not, then I will end these lectures. So remember to assign your attendance. And remember, a good dentist is always learning. Yeah, with that, thanks. Yeah, I'll see you next week.
Thank you, Doctor.
Yeah, bye-bye.